All right, good evening all and welcome to the Alaska Eating Disorders Echo. This echo is jointly provided by the Alaska Eating Disorders Alliance and UAA Center for Human Development Echo Project. Funding for the Eating Disorders Project Echo has been provided by the Alaska Community Foundation, State of Alaska, and the Alaska Mental Health Trust Authority. My name is Erin, my pronouns are they, them, and I am an echo coordinator with the Center for Human Development's Echo Project. These biweekly sessions offer a forum for Alaskan interdisciplinary healthcare professionals to connect with eating disorder experts. This is the fourth of 6 sessions running from September through November, and each session includes a didactic presentation from a subject matter expert, followed by a Q&A and case presentation, which will provide an opportunity to engage critically and collaboratively with illustrative examples of important and noteworthy topics related to eating disorders and their treatment. Our series has been approved for continuing education credits, and participants can claim 1.5 credit hours per session for this ECHO series. In order to claim these credits, you must attend our live session and for at least 90% of our full session time, and you must complete an evaluation form. After completing that evaluation, you'll be redirected to receive and download confirmation of your continuing education credits. At the end of the session today, a link to that evaluation will be provided in the chat box, and so we invite you to keep an eye out for it. And I also encourage those who aren't needing continuing education credits to fill out that survey, as it also just tells us how we're doing and how we might be able to improve. All right, before we jump in with today's program, let's go ahead and offer a few Zoom reminders. If your internet connection does not support audio, you can find a phone number to call along with a meeting ID in the chat box. Closed captions are automatically generated and available by enabling, or can be enabled by selecting the CC icon at the bottom of your Zoom screen. Again, we invite you to take a moment to turn your camera on so that we can get to know each other a little bit better. The camera icon is on the lower left of your Zoom screen. We do ask that our participants keep their microphones muted during presentations and when they're not speaking. And you can mute and unmute yourself by selecting the microphone icon, again, on the lower left of the screen, or by pressing *6 if you're calling in via phone. And whether or not you've joined in an echo before, it's important to know that engagement with the group is integral to the all teach, all learn philosophy that underpins our program. And we encourage everyone to ask questions and make comments during our session by utilizing the chat box, or when appropriate, by raising your hand and sharing directly with the group. You're also welcome to private chat myself, the session host, or any of our hub team members if you'd like your questions shared anonymously. To help further build connections and foster participation throughout our echo, we like to start each session with introductions. However, in the interest of time, we'll go ahead and do those introductions via the chat box. And participants and hub team members, if you could go ahead and introduce yourself by sharing your name, role, organization, where you're joining us from, and a little bit about what you hope to get out of this echo. Finally, please note that the opinions of our hub team members and presenters are their own and do not necessarily represent those of AKITA, UAA, or any ECHO sponsor. Additionally, Project ECHO is not HIPAA compliant, therefore we ask that no protected health information be shared or displayed at any time. And so we thank everyone for following those guidelines. Finally, I'll go ahead and take a brief moment to pause for a land acknowledgement. Though this is a virtual space, our ECHO team is joining you from Anchorage, Alaska, and as such, we want to thank the Dena'ina people for their stewardship of the lands, water, air, and all life that sustains us within their traditional lands of the Cook Inlet region. We respect the Dena'ina cultural ways and their homelands and shall strive to be good neighbors. All right, I'll go ahead and turn our session over to Beth from the AKITA team to share a bit about the vision that's driving this initiative, the purpose of our ECHO, what's on today's agenda, as well as to offer some reminders about best practices and language when engaging in today's discussion. Over to you, Beth.
Great, thank you, Erin. So I am Beth Rose. I'm one of the co-founders of the Alaska Eating Disorders Alliance, and I'm thrilled to welcome you all here this evening. It's just wonderful to see so many people join us from around Alaska and from so many other places. Our goal of the Project ECHO is that together we can grow capacity within our local healthcare system to better understand, diagnose, and treat eating disorders in Alaska and beyond. During our time together, we will be learning from the elements of the formal echo, as well as the ways that we interact with each other. Words matter and they are powerful, and this is an open space where all voices and bodies are welcome. We encourage you to be mindful and to seek ways to use inclusive, non-stigmatizing language when you ask questions or make comments. And I'm going to start out with an outline of this evening's agenda. We are going to begin with a presentation by Dr. Laura Hill titled The Neurobiology of Eating Disorders. And I and several of the Hub team members had the pleasure of traveling with Dr. Hill as she came to Alaska in September and offered presentations in Anchorage, Palmer, Juneau, and Sitka. I think you're going to find her research and her presentation tonight to be fascinating and to be very useful. Dr. Hill is an adjunct associate professor of psychiatry and behavioral health at Ohio State University, an assistant clinical professor in the Department of Psychiatry at the University of California, San Diego. She's a co-founder of the TBT-S Training Institute, which began in April of 2022 this year, and which you'll hear more about soon. Dr. Hill is one of the original founders of the Academy for Eating Disorders. She was the director of the National Eating Disorders Organization, now known as NEDA, from 1990 to 1994, and was the founder, president, and chief executive officer of the Center for Balanced Living from 2000 to 2017. She is highly recognized in this field, and Dr. Hill is a recipient of the Muskingum University Distinguished Service Award and the NEDA 2011 Laurie Irving Award for Excellence in Eating Disorders Prevention and Awareness. Dr. Hill is a 2012 TEDx speaker on eating disorders from the inside out, which I highly recommend that everybody watch. And she's providing eating disorders treatment. She's spoken internationally, and she's conducted eating disorder research for more than 40 years. Following Dr. Hill's presentation will be a brief question and answer. Our session will conclude with a case presentation by Holly Brooks, two-time Olympian, retired professional athlete, executive coach, and licensed psychotherapist. You're in for a real treat with both Dr. Hill and Holly Brooks speaking tonight. So now I'm going to turn it over to Dr. Laura Hill to share her didactic presentation.
Dr. Hill, you're still muted, so if you want to just come off of mute.
Thank you very much, Beth. And thank you, Aaron. And I appreciate so much being a part of this ECHO series. And to be able to have the whole area of eating disorders be echoed throughout your state, which I have found to be an adventure and an experience that is of the many extremes that not unlike in health, but in the reality of your landscape. So as Beth said, this is the presentation focus, but I do need to claim from the beginning that there could be, I need to disclose that I am the lead author of the book, Temperament Based Therapy with Support. And that book will be utilized concepts from it throughout the presentation. So it just came out in the spring. So I'm going to start a way I often start, but it starts with nature. And I found out when I was in Alaska that Alaska doesn't have poison ivy, but Ohio and many in the lower states do. And poison ivy is an ivy that begins to grow up and onto the trees, especially. And if you get it, it's extremely irritating, and it's just so itchy, and you want to scratch it. And the more you scratch it, the more it spreads. And the more it spreads, there is even a phase, especially during this season in the fall, that poison ivy begins to look beautiful, just like the illness of eating disorder. Has a period of time where people may say, you've never looked better, you look so good. And then the patients will say, but Dr. Hill, everyone says I'm looking fine and I feel fine and I've never felt better. But the problem is the illness then begins to take over and begins to encompass and take the life right out of the tree, to the point that the illness takes on more deaths than most mental illnesses. So I'm going to move from that very image and from the loss of that to be able to dive right in to talk to you about another aspect of nature in order to begin to understand eating disorders from the aspect of this very plant. And this is a Venus flytrap. If you don't know what it is, it grows in the more in the Carolina areas, but it is a carnivorous plant. It actually eats the flies that land in it. But when I explored and thought about this plant, I thought this plant says even more about helping us understand how the illness of eating disorders develop. And so first, I want to just explore with you what the environmental messages are. So let's take the top of the Venus flytrap and the kind of the teeth of it, and let's look at those teeth as various aspects of the environmental messages that we've really focused on since the illness was diagnosed first in 1980. And that is, it was seen primarily as an environmental or a social illness about eating. And so what would happen is those pressures might say, I'm sorry, but there's a thing that eat less food, no fast foods, reduce your calories, be thin, be thinner, be the thinnest of all, exercise more. So many moment by moment, hour by hour pressures coming at us. And then those environmental pressures were in fact faced against the genetic influences. And the teeth from the bottom of this particular Venus flytrap, we will say, are some of the genetic traits that individuals may inherit. And when you combine those traits, make the person more vulnerable to developing the illness. And some of the traits that bring that vulnerability is a perfectionistic trait, or an inhibited or an avoidant trait. Or what you will learn some about is interoceptive awareness has an aberration in this trait that develops with for people who have all the illnesses of eating disorders. An anxiety trait, the intolerance of uncertainty, or another way to be looking at it is difficulty in trusting one's decisions. And obsessionality, thoughts get stuck and just ruminate over and over, is a trait if that tends to happen at various times in one's life. Also, an impulsivity trait occurs, whether one's anorexia or bulimia or binge eating. And a competitive trait may also be present. But these are just a few of the combination of traits that, when coming together with the environmental pressures that result in when these traits that increase the vulnerability and the person moves into we always thought the environmental pressures, that those were the aspects that come together to bring in the malnourishment, or what we will say is the diet and the dieting that occurs. And that's like the fly entering as they diet more and the malnourishment begins, or the upset in the malnourishment. Now, we thought that was primarily the aspect, but we will also need to add the hormonal aspect, and that malnourishment is triggered also by the hormones that are rising during puberty, making the vulnerability cause these areas and these teeth to be magnified even more, causing the Venus flytrap to close in around and literally capture the individual's thoughts, feelings, experiences, behaviors. And at this point, when the illness begins to take off, the illness begins to even eat on the, begins to devour from the inside out the individual. And so we may have thought it was an illness of social pressure. That certainly triggers the illness to become further worsened. But we are now realizing also that those genetic traits are the traits that not only set up the vulnerability, but then the hormones cause the genes in those traits to switch to a higher level, and the traits become even more intense. So people will tend to say, well, what happened to my wonderful child? Or what, it never was this bad. I feel like he or she's becoming another person. And in some ways, as those traits take over, we know that from puberty on, the genetic influence is even stronger than the environmental, causing the illness to increase vulnerability. So how in the world do we address this? And I'm going to explore that tonight in various ways. Let's continue with the Venus flytrap, because what we have realized is you might be able to look at it from various angles, but how can we currently literally reopen this and let the person be able to breathe again, to be able to be well and be able to live on again. And what it takes is the family support, the clinical support, the dietary and the potentially medication support. And it takes all of us to pry this open together. And so, in other words, if the dietitian is helping the individual and we're helping the clients begin to look at, all right, you've got an obsessive trait, but it doesn't always need to work against you in a destructive way. I actually assessed the clinicians when I would be hiring them in our clinic. I wanted our clinicians to have an obsessive trait. I wanted them to have a compulsive trait. Those traits, when they are not disordered or dysfunctional, make the clinician a better clinician. They certainly get their notes done in an effective time. And so I love a perfectionistic trait. In fact, when I want my surgeon to have a perfectionistic trait. If I was going to have surgery, we want those traits to come through. We just don't want the dysfunction of them. So when those carbs and those proteins come together and we recognize the anxiety, but how can we help lower that anxiety? And with the support to be able to help with the dietary and the competitive and the more family support and helping to draw out the avoidant tendency with some medication. We can't stop all of the social pressures because they will always be there. But when we can bring enough support in and have the therapeutic team work with the support and the clients to be able to help shift the traits that have gotten too far impacted into a dysfunction and bring those traits back to a productive expression, then we can reopen that very aspect of the Venus flytrap and let the person be able to live with the ability to not harm, let the illness harm them as well as it had been. So in the development of trying to understand eating disorders from the time that they were first diagnosed, we didn't understand what the potential and what was going on the inside. We didn't know really until the gene was sequenced in the 2000, and then the technology began to grow, and we could begin to look at eating disorders through the fMRI, the functional magnetic resonance imageries, and hundreds, if not thousands, of articles in the last 20 years have been published now as we're looking at illnesses from the brain circuit level. And when that began to happen, we began to realize that, yes, the social pressures are very real, but they are not holding the impact that creates the vulnerability and creates the illness severity nearly as much as what the traits and the gene consequence are. So we developed what we call TBT-S, Temperament Based Therapy with support, and the support being those who can help and work from home, from friendships, from work. And we developed this therapy because we saw how many gaps were going on from cognitive behavioral, from DBT, from RODBT, from ACT, all the therapies that have been evolving through the 90s were not hitting core aspects. So TBT was developed to be a part of the mix, and in some ways, a part of the ingredients. And that we began to realize that supports are as necessary for adult clients as they are for adolescent and children. So TBT-S was developed to fill the gaps. So let's try to think about eating disorders from this perspective. If you have blurred vision, or if you're wearing glasses, nobody thinks twice about your need to wear glasses. They just assume you may have stigmatism, you may have farsighted, nearsighted, but let's say you're farsighted. You can see things in a distance pretty clearly, but the blurring occurs when you're trying to read close up. And so you have difficulty seeing, and the optician says you are farsighted. We're going to have to correct that blurred vision with glasses. So we don't necessarily disagree that that farsightedness is probably due primarily to retinal abnormalities. We've got circuits going from the retina to the optic area of the brain, and they are not firing with enough accuracy in order for the brain to be able to see the images clearly. So the action is you get eyeglasses, you just get glasses, and you correct the retinal abnormalities instantly because of those glasses. Simple compensation to correct for the neuro abnormality. So now let's look at blurred decisions. So when a person may have an inability to trust internal sensations, to be able to trust a decision, like they may not have that gut reaction. They may not be intuitive enough. And we have traditionally, from the clinical side, assumed that the person just needs to learn how to listen to their intuition. Maybe they weren't mindful enough. They weren't eating in an intuitive way enough. But what we are now learning since the 2000s is that many persons with eating disorders do have a difficulty trusting open-ended decisions in any area, whether it's food-related or other areas. And the fact is that that's not because they're not being mindful. It's because they have circuit alteration difficulties, not unlike optic nerve, only they're in different areas of the brain, and there are more than one set of circuit aberration. And as a result, it's made it more complex and difficult for researchers to identify what's going on until more and more research has come in over the last 20 years. So what are the brain circuits that contribute to eating disorders, just like the optic nerves are contributing to poor eyesight? And some of those are, and it's important that you be introduced to them if you don't know them already, is the dopamine circuit that comes up. This is a critical circuit that is involved in decision-making. And this part of the brain up here is where your executive decisions are made. So when you're consciously thinking through and trying to be open and mindful, you are dependent on this circuit coming up and giving you information. And this circuit of dopamine, literally every time you make a decision, you or I make a decision, the dopamine literally gives a little spike if it thinks it's a good idea, if the body is assessing it's a good idea, and the brain takes in its experiences and takes in its body indicators, and the dopamine will give a signal with a rise. So you can actually see it. If you're in the fMRI, you'll see the rise in the dopamine. Now, what would happen if the dopamine was rising too high and it was only rising all the time so much that then you would just probably, and then you also might have had an impulsive trait, then you would think, oh, that's a great idea. And you would impulsively end up going into activities that would be hard for you to hold yourself back. Because we also know that many with binge eating and bulimia have an extreme rise in this, significantly higher than what control healthy brains have. And then we also know that there's an inhibited area up in here in the orbital frontal that is not doing its job. So you get all desire, high pleasure at times, and yet no holding back. So it's all gas and no brake is coming in. Whereas for anorexia-oriented parts of the eating disorders, this is firing extremely low. And so the dopamine, when the person is thinking, maybe I should do that, there's no good idea. There's just a flatness. So the person may think, well, maybe I should take this course. No response. Well, maybe I should take that course. No response. So it isn't that the person isn't being mindful. It's that they are unable to have an accurate reading of what they should do intuitively because the signals are inaccurate. Also, another area that is misfiring with eating disorders is the caudate area of the brain. And that's this area right up here. So if there's a lot of distress coming out of the emotion center here, and it's sending literally signals right up here, which is weighing the pros and cons, for example. It also takes the emotional responses and then gives information to the front of the brain to make a decision. And we're finding that if it is, if the dopamine is firing too high, then the caudate is literally we're finding underfiring and letting all of that seem like a pro to the front of the brain. So we're going to do whatever the impulse says to do. And for anorexia, this comes up as all cons. So it's saying, no, don't do it. Don't do it. And literally, this area responds with enough fear and concern that the cons literally are telling the brain, this is not a good idea. And the only reason it's telling that is because it's getting misinformation, malfunctioning signals from deeper in the brain. And so the thoughts are assuming this is accurate when in fact the signals down below are inaccurate. And another and third and final key area I want you to know about is the insula. And there is one on each of your temples under those folds of those gyri. And the fact is the insula is the hub of your inner sensations. Any physical sensation that you experience, whether it's through your hands, when you're touching texture, whether it's your taste, whether it's your hunger and fullness signals, whether it's your pain signals, those signals that may come from anywhere area of the body have to filter through the insula. And the insula is the center of interoception. It's the center of, if you're going to have intuitive sensations, it's dependent on the insula to be accurate. And what we're finding is with eating disorders, anorexia, bulimia, binge eating, the insula is over or under firing, depending, but often under firing. And as a result, there may not be a sensation of fullness. And the binge eater does not know that they're feeling full, not because they're not mindful, but because they cannot sense it, because the signal is not being sent to the front of the brain to acknowledge it. It is like a stoplight that isn't working. So the person has to decide, do I go through that intersection or not? Because this is so under firing. And we're finding that therefore the glasses, if I could provide insular glasses for the insula to be able to say, okay, this is under firing, just like your retinal neurons are under firing, we're going to give you glasses. Well, this is under firing, so we're going to give you insula glasses. Wouldn't that be great? Well, the fact is, we've just learned that it's the insula that is one of the circuits not firing. We are testing in ways to be able to try to wake this up, but we don't have insular glasses yet. So what do we provide for these to compensate for the circuits that are not working? We're literally studying deep brain stimulation as I talk tonight. It's occurring certainly in San Diego. It's occurring at multi-hospital, university, and private sector sites. Going in and literally going to that dopamine pleasure circuit and trying to stimulate the nucleus accumbens to literally start regularly firing when it's under firing on a regular basis. But that isn't ready for treatment application yet. So another option may be optogenetics. That's certainly being studied in San Diego, where they will take laser surgery and without being invasive in the brain, they will take the laser and literally wake up certain neuron cells in order to start firing again. And in genetically obese rats, they have literally been able to stop the binge when they are doing this. The problem is it's not ready for human and treatment application. It's only being done on rats at this point. So we've also begun looking at transmagnetic stimulation, TMS. It's showing some validity for BN, but less so for AN. But they are continuing because it is not invasive. But it has not shown validity across the areas of eating disorders, especially anorexia yet. We're looking at medications, and medications have been studied for 3 decades now. A common one studied is fluoxetine for bulimia, olanzapine for anorexia, or topiramate for binge eating. Those are all very constantly and actually looked at as the common medication for many of these illnesses. The problem is there are side effects because the medication looks at all the dopamine or the serotonergic or the noradrenergic sites in the brain, and maybe not all those circuits need extra medication. So as a result, it's not valid as a sole treatment. So what do we do? What we do is just like what I was saying with the venous flytrap. We are left with manual interventions, and the manual intervention is critical because that's all we have at this point. Now, I'll just give you a quick story, an example of that. My father was a builder, and Dad was in a situation where he was asked at one point to build a cabin for a camp. He said he'd be glad to have his company help do that. And so he calculated all the materials. They were going to donate the materials so that they could have this cabin built. He loaded the materials, the tools, up onto the major semi, and they were bringing it into the campsite in order to build the cabin. And as Dad is driving in with the semi, the camp director comes out and said, "Oh my gosh, I hadn't even thought about this." But the reality is there's no road to get you to where the cabin that we want built to be built. So you can't take the semi there, and you can't take the forklift that's on the semi, and you can't take any of the tractors back. So Dad got out and he said, well, then we're going to have to do it ourselves. We'll do it manually. So literally all the campers were gathered together, all the camp counselors, and everybody started putting 2x4s on their shoulders, carrying in 2 or 3 boards at a time, the toolbox, the nail aprons. Everybody went into the trail, left them there, came back for more supplies, went back down the trail, back for more supplies. It took all day for everybody and some of the next day for the tools alone to get there. And then Dad said, now we're just going to have to manually build this together. So I'm going to show you how to line up the boards. Let's start making the first wall. Then he was showing them how to pull the wall up, and literally board by board, piece by piece, he began to help coach everybody working together to be able to make each wall, then to bring the walls to a place where they could hold each other up, and then be able to help the people learn how to use the tools in order to make the walls, in order to make the cabin. And in 2 weeks, they were actually able to complete the raw part of the cabin itself. So they began to make that manually. And so when we look at manual interventions, who are we thinking needs to be involved? The therapeutic team, not just the construction team like my dad had, which consists of the clinician, the dietitian, the medical professional. But we also need the manual intervention to include the client and the supports, because without the client being as actively involved and in every part of the way and the supports, then the treatment, just like the cabin, is not going to be built as effectively, as efficiently with the manual resources we have. So the TBT approach shares we literally share the neurobiological information with both the clients and the supports. So that means the clinicians are learning what those neurocircuits are that I introduced you to tonight, and beginning to say, you need to understand that this is a neurobiological aberration. It's not because you're not trying hard enough, and therefore you shouldn't need glasses, or now that you're 18, you should be able to, you've outgrown those glasses, you shouldn't have to wear them again. No one thinks that about glasses. Why on earth are we thinking about that with eating disorders? Because we now know that those eating disorders come from a neurobiological base, and we help the clients identify what their own traits are, their own genetically determined traits. What is each person, each client's profile of traits, so that they can realize what their traits are to begin to utilize their traits to be the best of who they are, and to use their productive traits to help with those who have got those traits that have gotten too out of hand and started causing triggering symptoms. So let's think and go back to nature for a minute, because temperament, since we're filling in the gaps of other eating disorders that really focus on the outside, the behavioral symptoms that are the branches of a person, our expressions, those symptoms, we're now saying the person is not complete without recognizing the roots of what feeds those symptoms. So temperament consists of one's traits, the neurobiological networks, and the genetic foundation. And so those are the very aspects of our own life that feed, if this is our person and our being, the trunk of who we are and how we grow and express ourselves through our life. This is grounded in our traits. And so why are we not assessing what those traits are? Because otherwise it'd be easy for a clinician to say, well, you need to be a little more outward and a little more variety filled. But if they're highly introverted because the trait is introverted, and if they are a little more inhibited, then we need to honor the trait of the individual and recognize they will never naturally be as extroverted and as variety and novel seeking as others, because that isn't in their trait mix. I don't expect an evergreen tree to be a deciduous tree. I don't expect an aspen to be a spruce, nor should I expect an introversion to be an extroversion. So let's clarify what is temperament. Temperament is consisting of the bottom of that Venus flytrap, the biological foundation to our personality, those innate features that are genetic and neurobiologically established that impact our thoughts, our feelings, and our behaviors over a lifetime. Let's make sure that you know the difference. The temperament is our genetic and neurobiological side of our personality. Our character is how we express our temperament within the environmental influences we experience. And I want to say that again. While temperament is the genetic and the nature side of who we are, our character is how we express our temperament, our traits, within the environment that influences our experience. So that tree is only as good and as healthy as the environment that it's in. So we take those very traits that are part of one's temperament that I introduced you to through the Venus flytrap, and those traits can lead to symptoms that can become disruptive and harmful. What is the difference, you may say, Laura, between symptoms and traits? Because clinicians can, and many times clients and supports get them mixed up. Symptoms are your outward behavioral expressions. They're the indicators of the illness, like a binge or self-induced vomiting or excessive exercise. Those are examples of symptoms, and symptoms can be reduced or eliminated. I want my clients to be able to walk away from binging or vomiting or extreme exercise. I don't want them to walk away from movement. I want them to walk away with the symptom that was being harmful or disruptive. Traits are the genetically programmed innate features. They can be intentionally shifted if there's a trait that, such as impulsivity, that's triggering a symptom to binge eat. Then we want that trait to tone down, but I can never, nor would I want, to be able to take the impulsive trait away, because that could be the very gift and strength that that person needs to get through various aspects of their life. So you cannot, even if you'd like to eliminate your traits, eliminate them, but we can refine them. And we have to do that intentionally. It doesn't happen automatically. Some of our traits are just automatically productive. Others take some refinement. So TBT-S clinicians help clients and their supports to identify what traits they have. We use instruments. We have a profile checklist, trait profile checklist, so clients can identify their traits and how their traits are currently being expressed, whether productively or destructively. And adult clients and supports learn to use the same tools, just like when Dad was teaching everybody to build that cabin. Everybody was learning how to use a hammer and the screwdrivers, how to bring that wall and those boards together to make a wall. And so the hammer and the screwdrivers were the tools that are that basic. And TBT-S just began to realize sometimes clinical tools are way too complex. What is something simple and basic that we can help use to build that wall of traits stronger, instead of assuming there shouldn't be a wall there? So here's an example of the trait profile checklist. And there are 54 traits that are taken from evidence-based personality models. And the client works with the supports and they evaluate themselves on which traits they have and how they're currently being addressed. So the traits trigger our strengths as well as our symptoms. You may say, I love my husband and he drives me crazy. I love my partner and she drives me crazy. The same trait that can be frustrating can be the very thing that you fell in love with. So that's typical. We think of that all the time, but now we've created a treatment to augment the other treatments that weren't addressing the productive side and addressing traits at all, and start saying, let's acknowledge those because they have a huge impact on the symptoms. And if you're only treating the symptoms out here, then you're probably not going to be able to help really change things over time. So let's take a determined trait. And how might that be expressed in a symptom? Let's say extreme or overexercise. And oops, oh, darn, what did I just do? Okay, there. And so the overexercise, but we want to take the trait or the symptom away, but I can't take the trait away. It's who I am. So we can work shifting that to maybe instead of overexercise, just the individual may say, I get great pleasure and can actually work very productively when I use my determined traits in my intense work projects. And so we can refunnel that determination to make it productive instead of destructive, the overexercise. Let's take another example. So let's say you have an impulsive trait, and that may lead to binge eating. The impulsive trait may also lead to one of my clients went into graduate school. She was doing literature searches, and she said she just impulsively one night started into this new lit search, and she found all this new information and became so invigorated by it. She decided to write the research paper on it, and then she offered to help somebody else when she heard about the topic they were working on. She goes, oh, I'll help with that. And she began doing lit searches for them. And she said, then I began the more lit searches and the more I was following the impulse of these various topics, I was binge eating less. And I began to realizing I was binging out on lit searches, which was very productive. And so we don't get rid of the impulsivity, but this particular client is one of the most amazing. She is one of the most productive researchers in her psych department at this time. And then let's take a detailed trait. And the person may have a very detailed ritual when they purge. But if we took the symptom away, then you may say, well, how can we respond and help the person who is detailed when people ask them overall questions? And the client learns a simple tool by saying, just give me a couple options. And the more we just give somebody a couple options, it helps compensate and becomes the very glasses for the inability to trust those decisions. So we ask a manual question, give me a couple options to what do you want to do tonight? And the glasses go on, well, give me a couple options and I can then make the decision. So example of a TBT-S tool to assist in the inability is that supports and clinicians help the supports learn to say, I'll offer you a couple, 2 or 3 options instead of saying, what do you want to eat? Or where do you want to go? Or how are you feeling? And what we know is the individual just may have a brain freeze. The fMRI literally just stops showing the front of the front of the brain can't respond because the lower information is malfunctioning. But when you say, let me give you a couple options. And as a clinician, I began to teach myself, all right, instead of saying, how are you doing this week? Or how have you been since I last saw you? I began to ask, so are your symptoms better, the same, or worse than the last time I saw you? So I gave him a 3-part option, and then the client was able to reason through and use the front of the brain to compensate for what the inner area could not help inform. So it's a tool that clinicians and supports can offer. And the very same tool or glasses is give me a couple options. So these become the manual glasses. The tool is the glasses. The adult client is the expert to test out which tools fit best. I always liked the hammering, but my sisters liked using the screwdrivers and working with the screws. So the fact is, everybody needs to recognize which tools fit best with their own traits. And so the toolbox that TBT-S developed depends on the client knowing their traits, trying on different tools, and helping each client see which tools fit best based on that. So the client is the person that we actually have typically focused on. And in the brain from 2000 on, we focus primarily on the neuron circuits. They're front and center. The client is the neuron, front and center. And in TBT-S, we're saying, nobody can tell us better than you. So if we're saying there's an insular problem, some people can't tell if they're hungry. Do you sense that? Can you tell if you're hungry? Can you sense when you're hungry or not? And we ask them with very structured handouts to help us know those answers. The client will give us those answers. So now we also are looking at the brain, because we've constantly in TBT-S turned to the brain to be our guide in helping us understand what's going on in the illness, as well as what to do about it. So if you are just looking at this blue area, which is the neuron, which is this area, then you're not focusing on the brown cells. And the fact is, the brain uses more of these brown cells than it has neurons, 15 times more actually. And these are called glial cells. Now, the function of the glial cell is to serve as support. And so literally, the glial cells not only support by holding the neurons in place, they also help feed the neurons, they help eliminate the waste, and they even protect the neurons through the blood-brain barriers. And so that is the very role of supports. The supports are helping use the same tools to support in the feeding, getting the food ready, or buying the food for the fellow adult, or they may be helping the client protect that client from hurting themselves too much, but they're also helping create that structure to hold things in place. So the people who offer support are supports. That's the glia. And then we knew, just as the brain requires support, that treatment must. And the irony is, the more we started studying and asking the clients what they thought of the various TBT-S tools, the adult clients actually asked us to include their loved ones and their supports, their friends, their roommates, because they said, we want them to know the same messages, because they won't believe it if they hear it from us. So we started inviting the spouses and the partners, the parents, the friends, the colleagues, the pastors, the children of the clients, and the relatives, and the neighbors. They all started coming to the neuro groups and to the temperament groups, and they began to learn the same tools. So how do support persons provide the manual supports? By using TBS tools and learning what neurobiological findings are, so they can understand the illness. So then you may say, but Dr. Hill, what about trauma? Because trauma affects so many with eating disorders. Well, trauma affects eating disorders, but it also equally affects every other area of mental disorders. And let's say the trauma hit, if it's a specific trauma, at a point in a person's life, and literally took that genetic tendency to grow up and better and broke that down. But the amazing thing is that those traits didn't give up. I bet there's a determination trait in this tree, because it may not have grown the way it was going to once grow, but it grew in and around. And when there were plenty of supports, that indentation is much less, the extreme is lessened because of the increase of the support. So the impact of the environment on temperament in creating character is very real. So when we are looking at whether it's the environmental influences or a trauma, I took these pictures while walking on the trail in Anchorage. And I was looking at this tree and those around it and realizing that literally another tree a little farther up was the very same type of tree, but it didn't have the environmental ability to grow as well as this one. And this one was even more traumatized and could not grow. But this one, who had more support, was able to grow better and actualize its traits even better. So too, when we include support in treatment. So clinicians with research information to offer clients and supports in TBT-S focus provide the tools or the classes to try on using more external structure, more support, more practice of those tools in order to become helping the client shape their traits, to provide the clients of all ages and supports the structured tool to help the clients identify their own traits, to be expressing those traits to the most productive solutions, to simplify the neurobiological, to take simple manual, neurobiologically driven traits, and to actively practice the tools to bring out the skills to become all one is meant to be. So I was going to use this tool, but I want to be also open it up because there is a case to be made, but I want to acknowledge my fellow contributors to the development of this treatment, the book that I'm grateful that we have out, and the training of the Training Institute. And I'm going to stop sharing at this point.
Thank you so much, Dr. Hill. As you can see, there's so much information that Dr. Hill is sharing, new research that's out there. There is the opportunity to really use this in a way that actually Dr. Hill and I were on Line 1 Your Health Connection. It was Prentice Pemberton said this is a real strength-based approach to addressing eating disorders. And it's a fascinating way to think about the traits that we've so often thought of are disruptive and damaging and scary, and how they may be used to help strengthen someone in their ability, in their recovery path. So I'm going to open this up to questions, but I wanted to add very quickly that Dr. Hill will be returning to Anchorage in April of 2023 to teach TBT-S and over a 3 to 4 day session. So just be aware of that. We'll probably try to do this if we can, at least part of it in a hybrid manner, much of it in person. So I'm going to open this up, and please feel free to raise your hand. And I see one hand, and then you can also use the chat function. And I'm going to call on Maggie if you want to unmute yourself and ask your question.
Hi, I just was really curious about the experimental treatments that like the optogenetics and the transmagnetic stimulation. And I was curious, just as an occupational therapist, we work a lot with that reticular activating system and the limbic system and sensory integration with our patients. And we're terrible at studying and putting it into clinical trials and making it make sense because everybody's so unique. But I just was curious, you know, in a sense, it's the same sort of strengths-based approach to try to teach people to sort of seek out, you know, what their nervous system needs, but in a more functional way. And I just was curious if there's any sort of other research, you know, related more to like sensory integration, or whether those approaches are showing some promising, you know, it's very in line with what you're talking about. And I just was curious if there's, you know, any sort of studies or overlap going on in that regard.
Dr. Hill, you're muted.
Maggie, your question is so important because in so many ways, eating disorders is so far behind the 8 ball in its research. And one, because we didn't have the technology, but now that we're trying to look at the technology, it's also needing, and so many of the researchers are just now beginning, I mean, just now in the last 5 years, beginning to collaborate with other fields to follow things like what is going on in occupational therapy. And when they're looking at the deep brain stimulation, for example, there are some outcomes that are coming out that are pretty amazing. The issue is, as you already said, every individual is an individual and every brain has its variations. So it isn't always going to the same absolute location, because if you had a grid over a brain, that can vary a great deal individual by individual. So the variation makes it difficult, but I think that's one reason why the magnetic stimulation is being looked at, but it's much more generalized. So they're looking now at computer models that are also leading to the very thing that you are addressing in the occupational area, because the more functional that we go to be able to recognize those signals and to help repeat those signals over and over to be able to bring some strength in a functional way, the better. So it's just on the edge of moving to fields such as yours to start collaborating more. For example, the mere fact that we're advocating to collaborate with the support people, the treatment, the researchers are not great collaborators sometimes with other fields. They're so in their own silos. And the reality is researchers have to start the collaboration. And then that also helps us translate that into treatments. And so the short answer is it's just on the edge of starting to be put together.
And I'm going to go ahead and just ask a couple of other questions, and then we'll around 7:05 we'll have Holly present. But let me ask, there's a question that came in that's a nature-nurture question about the temperament-based model of disordered eating. So if the roots of eating disorders are genetically and biologically or biological traits, then presumably there's a stable percent of people who have a genetically based eating disorder temperament or traits that are associated that can lead to eating disorders. But in recent years, particularly with the pandemic, we've observed a large increase in the number of people worldwide with eating disorders, even though the number of people with genetic vulnerability hasn't changed. How do we make sense of that for ourselves and our patients?
Well, what I'll say is that we experienced the research, the eating disorder research that's coming in is showing that those who, because of the pandemic and clients could not get out, and many were not able to even get access to treatment, the isolation magnified the symptoms. And so many clients relapsed. And in other cases, the illness had maybe been able to be managed because the traits were being able to be used productively, and suddenly the traits turned against the person because of the isolation. So the prevalence of the vulnerability has not gone up. A lot of eating problems have gone up, but not eating disorders. But I'll say the increase in the eating disorder diagnoses or prevalence appears to be much more from the relapse or from the character or the trait profile vulnerabilities that moved into a full-blown illness, but maybe had never been there. So they were potential. The prevalence is usually the same over time, but in that situation, it uniquely brought out the worst in many people. And then now they're trying to get them to be curved again. So I'm trying to say how to make that in a short answer. The short answer is the incidence does not change over time, but the prevalence took a bubble in the isolation, but is leveling out again. But the massive amount of problems were beyond eating disorders. It was all kinds of eating problems. And anxiety went off the chart, which increased or decreased the eating.
Great. And there's a question. I've got two questions, and then we'll probably have to end it. So maybe if you can offer some short answers to these. One of them.
That's hard.
I know. One of them you answered a bit already in the in your presentation. But it's a question probably about maybe impulsivity, and there's this link, and I think that there's still a little bit of not confusion, but thoughts about overeating and links to higher weight bodies. And there's just a New York Times article about atypical anorexia, right, and how people can have atypical anorexia being in higher weight bodies. But if there's a way to address overeating, which could be binge eating, and links with, and how do you address that in the health issues of obesity or being in a higher weight body?
Well, literally, researchers and the people who've helped create the criteria for anorexia, bulimia, and binge eating disorder, the whole discussion is continuing as we look at the continuum of extreme underweight to extreme overweight, and the causes are as varied. I mean, you can be extremely underweight due to many types of illnesses, not just anorexia. Anorexia is one, and it has a high death rate. And extremely high adiposity, not necessarily body weight alone, but the adipose or the fat tissue, extreme high, if you want to use BMI, which has its own problems, but if you use that, it's also deathly, associated with a lot of deaths. The issue is there's a huge area in the middle where the individual may be quite healthy and the body size and fat levels vary greatly. So the issue is not about the obesity, it's the binge eating and the traits and the inability to control the food because of the neurocircuit aberrations that is creating the binge episodes. Yes, that creates and adds to more fat tissue, and the person usually tends to gain more and more weight and adiposity. But not most people who are way more or are more and more obese do not necessarily have binge eating disorder. It's an illness that's a subpart of obesity.
Thank you. And there's an excellent one other question, but I think I'm going to hold this question, and we are getting other questions. And if there's time at the end, we will be able to ask a few more questions. But I want to also turn this over to Holly, and actually before I turn it over to Holly, I'm going to turn it over to Enzina to do the introduction. Enzina Marari is on our board, and she is going to be the case facilitator tonight. So Enzina, take it away.